So I'm Ole Nordheim, University of Bergen. Thank you both for very good talks. Alicia, you talked very wisely about looking into the future and the new Sustainable Development Goals. I'd like to challenge you. You said that we need both quantitative and qualitative indicators. Can you explain how can we use qualitative indicators to hold governments accountable for the measures they implement and the results they achieve?
Should I take a bunch, or can I answer that? So there are two types of qualitative indicators. One are qualitative indicators, things that cannot be counted necessarily, so changes in laws or regulations or institutions. Those, I think, are appropriate to include. There are other kinds of qualitative indicators of people's perceptions. So do Tanzanians feel like they are getting good maternal health care? Those kinds of indicators, I think, we know are plagued with all kinds of problems and should not be included as indicators to keep, to hold governments to account. Does that answer?
I just want to make a remark about the indicators, because that's a real problem, and we in the IRG are fighting with this a lot, especially when it comes to quality of care. And we have tried in our reports to put in pictures, just pictures of situations that reveal something of what you just said. And the interesting thing is there was zero reaction to the pictures.
So there's actually now a substantial body of evidence on asking women whether they were treated well during their stay in maternal wards. And if you ask them at the hospital, when they're still in the confines of the institution, they will almost overwhelmingly say yes, even if they were charged under the counter, even if they were slapped or not given privacy or spoken down to. If you ask them 6 weeks later at home, you get very different reactions. So I think the need to come up to refine quality and qualitative indicators is a big challenge for us.
There was a comment on the front row. No, I just wanted to respond to the question about qualitative indicators. So also to kind of give another suggestion, for instance, maternal death reviews are mandated for all countries. However, the findings of those death reviews and the conclusions in terms of what systemic actions need to be taken are never published. So there's no accountability for having learned from having studied those deaths. So I think that could be a positive indicator in terms of our countries actually publishing reports of the action taken after maternal death reviews. And so you kind of also ensure there's a quality loop in that they are bound to improve their quality in that sense.
I'm not totally sure that would not have unintended consequences. Because maternal death reviews are meant to be kept confidential. They're not meant to be used for litigation, for example. This has come up often, very, very often, lawyers trying to get a hold of it for litigation. They, depending upon how they're carried out, they don't get at systemic issues. They're often used to scapegoat individuals. So I'm not sure how, that's a possibility, but I'm not sure whether that would be appropriate. Also, the point about indicators is, and we'll discuss this more in the book launch, indicators have different uses. And if you want an indicator that's meant to mobilize global efforts and force, like maternal mortality ratios, it serves one purpose. If you want indicators that are useful for national planning, you want different indicators. And if you want indicators that are useful for programming or for holding governments to account under their international human rights and obligations, you want different indicators. So just saying what indicators work and what don't is not always appropriate.
It's Rune Nilsen from Center for International Health at University of Bergen. We are at a conference now in Norway where the focus is research and research training. what you have really challenged is how are we doing research training in Norway, but also internationally, because those of us who has been working with research training, PhD training internationally, see that it is almost impossible to address such type of interdisciplinarity into the research training programs. And I'm saying this because there are some work, and it is an initiative from the group behind the conference here to work on an international research school in Norway. And they can fall into the pitfall of copying the traditional disciplinary and counterproductive research training. So with this type of perspective, and you are coming from a big institution, what would you advise Norway to really address this or make this a possibility for research training with the interdisciplinary perspective, addressing this right issue? Thank you.
Well, I think, first of all, you're absolutely right. I mean, you can't see all of these different angles from one particular discipline. So in the book launch project I'll be discussing, we had 11 case studies with anthropologists, economists, lawyers, public health people, public policy people, really all kinds, urban planning people, really all kinds of different disciplines working together, which is hard. It's hard, as you well know, to do that kind of interdisciplinary research. But if you don't, you end up just looking at silos, at the small questions, and never challenging the way the frame has been created. So I think it's absolutely essential that the Research Council and that NORAD continue to, and even at a greater pace, encourage more multidisciplinary, more interdisciplinary work to get at these larger questions. Norway is really a leader, a disproportionate leader in global health, and I think it has the potential to do even more so.
Sorry, Alicia. Thank you. We have one more comment down here, and then we have Johannes Sundby, and then I think we have to take a break. Thank you. So,
it's working.
please take-
I'm Malcolm Langford from the Christian Michelsen Institute and University of Oslo. First, a comment to Per Faguli. I think he's left the room, but I want to partly disagree with you. I think his theoretical framework is slightly off. I mean, I think it's modernity that we're seeing in the health system. It's the perfection of the individual. And he's really bringing a postmodern critique, and a romanticized, perhaps, modernity that comes from Nietzsche, and saying that maybe people want other things. But I would suggest that a critical modernity framework is the best way to think about this issue. It respects that people have multiple identities, multiple modernities. Some people want to take more risks. But critical modernity also respects that we have rationalism and reason, and that we are not all savages throughout this world. And that even in the remotest Peru, people have reason and rationalism and may want a better and cleaner life. And so I think we need a more nuanced perspective, and I think critical modernity might give that. And then 2 short questions to Alicia. Can we get the UN 1997 guidelines on maternal health, the indicators in those, into the new agenda rather than just skilled birth attendants in terms of emerging obstetric care? And what about more progressive indicators on family planning and even abortion? Thank you.
I won't touch the questions for Per. Whether we can get the indicators, you know, the inter-agency expert group has been meeting just now. I think that'll largely be a political decision. They'll say that they're not collected at national level in most countries, et cetera, et cetera, et cetera. And you know, if we could get 1 or 2 signal functions, cesarean section rates, the most obvious being, that would be a major advance in my view. Family planning, which by the way, it shouldn't be family planning. People want to have sex. They want contraception because they want to have sex. And the insistence in the public health community on calling it family planning is a misnomer, and it actually creates distortions in the indicator and in who gets counted. I don't know, honestly, Mal. I think those are really political discussions and where the data reliability and availability lie.
I think the microphone is stuck somewhere. We can't have more speakers now. One are down there, I understand, it's very urgent. And Johannes Sundby, and then it's a break. I'm sorry. We can continue in the break.
So am I on or not? I'm on, okay. No, I'm just glad you gave me a chance to speak. But I was going to say the exact opposite of what my colleague at the back said. I've traveled from South Africa, thousands of miles and hours of sleeplessness. This is the best thing I have heard. I have spent my life with indicators. Really, I don't need lessons about apartheid and inhumanity and suffering. And we go through indicators, Alice, till kingdom come in designing our new society. So I'm familiar with all of that. And I'm not diminishing that because it's necessary for my life as a pediatrician. But I understood the brave new world that Fugeli. And I'm really sorry he's not here, but it's an indicator of his humility and whatever else I'd never heard of him before. But it's the finest words I've heard about public health. I'm a clinician who looked after cancers and kidney diseases. But when I heard talk like this from other people, there are people who wrote a book called Where There Is No Doctor. I don't know if you know that guy. He's a great guy from Central America. And they change your life. Primary health care and Alma Ata did that. But I must say what I heard now, although it is a vast landscape of uncertainties, I still understand that to be regimented as our lives are in South Africa and your lives are, with these endless stringencies, I think diminishes life. And although it's not clear what the answers are, I still like to hear original thinking rather than the usual stuff I hear. Thank you very much for having me.
One last comment then. Johannes Sundby from University of Oslo. I'm interested in pursuing a specific type of possible research, and I wonder if I can get some guidance on it. I think it's important to link some of the things that Tarek has said about where the reason for high maternal mortality is the way we see or treat or evaluate women. And then you say an issue of putting a gender-centered or putting the human dimension, including gender and social equity and things, into the agenda. And how can we better the research that takes account of how we treat women in society in general and understand how that is reflected through how we treat women in healthcare? It pertains to the way we treat or care for women who've been exposed to rape. It pertains to how women are used in the fertility industry, in surrogacy, and also abortion, maternal health, all those things. Can you give us some guidance about how we can go forward on that?
Well, I can tell you that women are not treated like full human beings. Maternal mortality is the culmination of women not having voice in their households, in their communities, in their society, being discriminated against, and having that discrimination refracted by indifferent health systems. As the Mahmoud Fatala quote that Tarek put up yesterday said, women aren't dying because we don't know what to do to save them. We've known what to do to save them for over half a century. They're dying because we don't think their lives are worth it. And that's the same reason why gender-based violence is so prevalent. It's the same reason why women have unpaid care work all over the world. So how do we fix those things? Is that your question? What kind of research? We're beginning to document it. You know, we're beginning to document it quite a bit. We have a lot of data on gender-based violence, intimate partner violence, violence against women. We have a lot of documentation on maternal morbidity and mortality. We have a lot of documentation about different kinds of regulations that discriminate against women versus men, harmful traditional practices. The question is, what changes? What are the leverage points to make changes in those norms, in opportunity structures, Those are complex, right? So sometimes it's shifting norms, sometimes it's changing opportunity structures within the household. Sometimes it's female education, which is enormously important, but there's also data to say that it's not just primary education, it's secondary and tertiary education that reduces gender-based violence. So it's very complex and often contextualized what is needed to make real change. We're not the same place we were 20 years ago. You know, somebody said, Tarek maybe said, nothing has changed. I think some things have changed. Thank you.